Hi, everyone. I'm Qasser Mukhtar from the Centers for Disease Control and Prevention. With my CDC, TAFINET, and CDC Foundation colleagues, I welcome you to part 3 of the Study Findings Interpretation series. We appreciate you joining us today. And as usual, we ask you to please introduce yourself in the chat box, write your questions in the Q&A tab, and yes, we will share links for the webinar recording and the written questions and answers next week. We appreciate your participation in the poll questions and evaluation. Your feedback is important to us. So in celebration of the World Field Epidemiology Day theme, which was on September 7th, and the theme for this year is collaboration. So I want to say how grateful we are for this collaboration with TAFINET, excuse me, the World Hypertension League, and all the audience who show up for these webinars, excuse me. So we're excited to share a few NCD-specific events and resources that have been developed in collaboration with our FETP partners. There is a symposia at the World Congress of Epidemiology on September 25th. So if you're there, be sure to attend that. Also, stay tuned for 2 new technical resources. There's a self-paced online course, um, non-communicable disease implementation research tool developed by Infinite. There's a new case study for program evaluation by SafetyNet. And then um, you'll also be happy to hear that um, writing, sorry, I'm going in the wrong order, apologize. And then TAFINET has launched an NCD resource webpage library, so where you can find all these resources and learn more about our efforts to strengthen NCD capacity. Um, the scientific writing course or writing a scientific manuscript course that you're very familiar with has now also been translated into French by our um, Canada FETP partners. Thank you, Canada FETP. We appreciate that. Now the course is available in English, Spanish, and French. And then Tefinet is working on a story on the 6-part webinar series that we concluded in June. Next slide, please. So I'm excited to share Tefinet's post where they recently highlighted the research methodology series. Incredibly, over 6,000 participants from 151 countries have attended this series. On the other hand, um, I'm not surprised to see these numbers because of the excellent delivery, discussion style, and the depth of knowledge demonstrated by our speakers who are among the most respected in their field. So thank you, Professors Welton, Lackland, and Weber, for your so generously sharing your knowledge with us month after month. We appreciate that. And now, today, uh, our faculty will discuss assessing and selecting the most appropriate diagnostic test for different conditions, including hypertension. And with that, I turn it over to Dr. Lackland. Thanks again.
Very good. Thank you. And thank everyone for the opportunity to do this. This has really been a highlight that we've enjoyed and being a part. This is kind of an exciting one that we now work with. This next piece, looking at predictive values. This is a little bit following up of what we did with part 2 when we were talking about sensitivity and specificity. And I'll begin with kind of apologizing. That was a real long one, a lot of content, but I wanted it to maybe kind of share, and now we will kind of reinforce some of those things that we talked about last time, as well as moving into this next important piece of looking at the predictive values. Again, our typical disclaimer. And today we'll talk about the assessment and selecting a diagnostic test considering sensitivity and specificity, and thinking of the rule in and the rule out types of rules, considerations. Thinking about the statistical concepts that when we want to implement a diagnostic test or use one in whether we're doing field work, whether we're doing work in the clinic. And then also describing the elements of determining the high value in particular of a screening test, something that we all of us here are very, very interested and concerned. So let's begin a little bit of reinforcement. Let's identify that good diagnostic test. What do we consider? First off, what's the purpose of the test? Well, the purpose of the test, as we've all known, is to identify with high accuracy if a disease is present in a patient, in an individual, and thus to provide, in order to do something, to provide early proper treatment or not treat. You don't want to treat the undiseased and waste resources in that piece. You want to think about the test characteristics to select the best test. Is this the best test to select this particular condition? If we think about that, we want to make sure that we look at those test characteristics. We want to consider it before we implement a test, before we say, this is what we want to use. We want to measure whatever condition. Look at all these things. Always making sure that we're looking at, is this really a good test? Is this something that we can rely on and actually do something about? So we want to ask this question, all of us. What is the purpose of the test? Why are we wanting to implement a particular test? Most of them right there at the top. Very importantly, screening, looking at patients and looking at basically asymptomatic disease. So they're not presenting with anything, and you want to say, do they have hypertension? Do they have diabetes? Have elevated cholesterol? Do they have other types of things? We want to see if this, and we use this in kind of a screening mode. Also, certainly very clearly diagnostics, which patients have the symptomatic diseases that we're focusing in. Predisposition, which patients, individuals could develop the disease. Looking at things, maybe an elevated blood pressure could lead to ultimate hypertension. Monitoring the disease. Are we doing this? Is the disease being controlled? How advanced is a particular disease? Has the disease reoccurred? Prognosis. Will the disease progress over time? And effectiveness. This kind of when they would do a test to see how effective is a drug or a particular intervention. All different things that we want to kind of consider. Perhaps the first question that we ask when we're selecting or recommending or interpreting a particular test. Choosing that test. Again, we think about, we've got some great tests, some great things are building up every day. We see a new test and it looks very, very exciting. And you think, boy, this is, and it gets more defined. I was looking at some brain imaging, just wonderful types of stuff. So the latest technology, though, should only be used when it's shown to be more cost effective than the established test. So they're great tests. They're really exciting. Get you looking there, but are they any better than what we currently have? And in particular, thinking about the cost effective. And again, the reason for doing a test should never be because we always have, because it's a habit routine. It needs to be, you want to take those parameters and carry them forward. Just one of me personally, when I come in and get my physical and I have a whole battery of laboratory measurements that I've taken, you've seen this too. At one point, I think I had about 40 different measurements, and a couple of them were kind of on the edge. And so I asked, I said, well, what do you do with this one? And they basically said nothing. And they kind of wonder, then why did we do the measurement? Another piece that we have to consider that we mentioned last time, but that we'll consider, and this is the threshold. So sometimes the tests are great and very, very strong, but where we put that threshold needs to be associated with a particular risk. Thresholds and limits, again, they kind of create this artificial category that sometimes can be misleading if they are misunderstood as boundaries between having a disease and not having a disease. And we'll give a few examples about that, but kind of think about these thresholds that are applied and how do they make their way into our consideration of a particular test. These are ones, one more time, we talked about this before, but just kind of getting these heads in a little bit more. Sensitivity, specificity. Sensitivity is the proportion of patients who have the disease or have the disorder who have a positive test. So sensitivity deals with individuals that have the disease. The specificity is the proportion of subjects who do not have the order, the disease, and get a negative test when it comes back. Specificity deals with those people that do not have the disease. What we like to see a lot, and I think certainly this is what the patients are interested in, the positive predictive value, the proportion of the subjects who test positive and then actually have the disease. Negative predictive value is the opposite, the proportion of subjects who give a negative test and who do not have the disease. The likelihood ratio, again, for a positive test is how much more likely is a positive result found in an individual as opposed to the without, and the likelihood ratio for a negative test is just basically the other, is how much more likely is a negative result to be found in a person with the disease. Just a refresher on the diagnostic test. Sensitivity, again, proportion of subjects who have the disorder, who have a positive result. Specificity, the proportion of subjects who do not have the disorder and give a negative test. Very important. Sensitivity and specificity are consistent for the individual test and the threshold regardless of what the prevalence of the condition is. Sensitivity, specificity always stay there. Very specific for the test. And as we look at something like this, what we're trying to do is to look at avoid the type 1 error, which are the false positives, and the type 2 errors, which is the false negatives. And so as you review a test, as you review sensitivity and specificity, you're starting to kind of think, am I concerned about the false positives? Concerned about the false negatives? What do I want to minimize? What are the consequences in these pieces? Again, a little bit of summary. We're selecting a test now. So a good sensitivity and a good specificity for a test is high, meaning that the test has a high likelihood of correctly identifying people with and without the disease. So thinking of sensitivity and specificity together, I can identify with good probability the people that have the disease and a good probability the people without. A test with a high sensitivity will correctly identify most people with the disease, basically ruling out the condition, i.e., this is where we were talking the snout. High sensitivity rules out a particular disease. A test with a high specificity will correctly identify the individuals without the disease. High specificity, thus ruling in the disease. Now, let's choose a test and protocol a little bit more. We have to think, one, what's the value of the test before implementation? Again, I'm kind of look at that sensitivity. What are the consequences of a false positive or a false negative. Also, I'm thinking about the affordability. Is this test any better than what we already have? Is it going to add something to the test? Again, a test should not be requested if its expected benefits are outweighed by its risk and cost. Again, kind of gets very confusing in these other pieces. Sometimes it's difficult to assess the value of a test when the risks are uncertain, or if the clinical or population benefits take some time that make it apparent. This is where you kind of find that test that some get it, then some don't, the value, and then you're spending a lot of resources, but you're not getting something on that other side. So always kind of looking and kind of considering before implementing.
Dan,
Yes.
talking about this and doing tests that perhaps are not appropriate at a given time is something we run into all the time in our patients in hospital. Someone's admitted to hospital. Maybe they've got chest pain and they're going to be evaluated for acute heart disease and maybe get some kind of intervention if that's appropriate. And what I find sometimes is that some of the young doctors will order all sorts of tests. We deal with the heart problem. Now we start getting all sorts of results for other tests, and it sometimes adds days to how long the patient has to stay in hospital before we can send them home. It's an inconvenience to the patient, an inconvenience to their family, and just as bad, a huge burden on the hospital, a huge extra cost, and resources that should be used for other people who need them are being taken up dealing unnecessarily with a whole list of tests that people say, well, now we got you in hospital, let's do everything we can. And what you're teaching us here is, I think, very relevant to this very common problem.
Dr. Weber, thank you, because I think there's a lot of textbook here, and I know that, but kind of building this in, it makes it so important is to we want to advance our knowledge about particular conditions. And I know for a long time, I knew these rule in and rule out issues and concepts. And so as we move this from sensitivity and specificity, now thinking about how you implement this and how you really apply these concepts to our selection of a test. And again, they're concepts in disease diagnosis, and it basically helps you select the appropriate diagnostic test. But it also emphasizes, almost to your point, this concern about overdiagnosis. And again, thinking of where the thresholds are and this other piece, and what are the consequences of something like overdiagnosis. The rule in, specific test, spin, basically is used to confirm a diagnosis. So if we're looking at specificity, what can happen? This is looking at people that do not have the disease, and they're being tested. So they don't have the disease, and so your concern here is that false positive. What's that concern for the false positive? And it's going to rule in a particular condition. The rule out, snout, is involved with a sensitive test. Sensitivity involves people that have the disease. Okay, so now how can you have the disease, you're being tested. So if you test positive, that's great. But if you test negative, a false negative, then that's the concern here. What is your worry if a person that you did a test, you failed to identify the disease and the person actually happened? I mean, things like STDs are very, very evident that you want to avoid. So are you ruling in, ruling out? Again, we'll speak about it, but most of our screening is a rule out. And one of the concerns that we have with this, again, is the overdiagnosis. And again, a correct medical diagnosis is made, but it's in one sense not necessary. And this is again where those thresholds can kind of come in to make a difference as we look. Are we moving the threshold a condition, in an area, and perhaps doing a little overdiagnosis. But sometimes that's bad. That's not good. It's not a beneficial. But sometimes you move the abnormal and you get the milder forms of the disease are diagnosed. And then you're kind of balancing that with the potential harm and risk. And sometimes that's a good thing if you're looking again at maybe this is a condition that will progress and you would like to have that kind of early identification. So lots of considerations that we have is a little more about overdiagnosis, and Dr. Weber's kind of referred this already. The drivers of overdiagnosis, again, technological changes, looking at small abnormalities, financial incentives that are used to do lots and lots of tests, and that we see all the time. What we do, let's do my new test, or let's do this part. And again, where that results in increased testing and treating, but penalizes the underdiagnosis. But not the overdiagnosis. Widening disease definitions. We see this all the time. Again, sometimes for positive ways, sometimes not. And again, thinking about the positive feedback loop in which detecting smaller, milder, and early changes leads to an overestimation of the prevalence of the disease, but then over to the overestimate of the benefits of the treatment. But sometimes this can be a good thing. And we'll talk about some examples where it's there, but something to kind of think about these considerations rather than just relying on just what has typically or routinely been done. So what are the issues of diagnosis? Again, we've talked about the downsides of overdiagnosis, the negative effects of unnecessary labeling, the harms of unneeded tests and further therapies, the cost of wasted resources that could be better used to treat and prevent a genuine disease. In turn, though, a test could detect an early stage preclinical piece of driving and look into the prevention strategies. So there's not any absolute, or this is horrible, that it depends on the condition, depends on the purpose. What are you trying to do? And this is just kind of introducing those different aspects.
In fact, one of the problems that does arise, Dan, is particularly in clinical practice. Sometimes it's more cost effective to do a shotgun diagnostic testing. For instance, I may see a patient and I'm wondering, do they have diabetes? Now, I could just do a very simple test and come to some sort of a conclusion, or it may be more convenient to order what's called a metabolic profile. And it's a standard test available in many countries of the world, where you get glucose measured. That's good. You get maybe hemoglobin A1C included, but you also get all sorts of liver tests, and you get calcium, and you get electrolytes, and so on and so forth. And if you start looking at 20 or 30 tests, very convenient or even cost effective to do it all in one time, something's going to be abnormal, something I hadn't even thought about or considered. And now I have to reschedule the patient to come and have another visit. I have to repeat the test. And 9 times out of 10, it's going to be normal the next time. And it's been a waste of the patient's time, my time, and the laboratory resources. Again, I think the lesson you're teaching is so important. Focus on what is important to know and important to do. And I think this is a big lesson that we need to teach our young colleagues.
Good. Well, thank you so much. And I think that was well put into the relationship. You're looking at diagnostics in the hospital, and that's a great value. So again, what are we looking for? What's our purpose of our study, of our assessment? What's the purpose of the test? And where is the biggest advantage to get to what for the purpose of administering the test. Perfect. A little more rule in and rule out, because it's kind of how we're thinking about the test and what is our purpose. Again, for rule out, this is a term in medicine used to eliminate or exclude something from consideration. For example, you would do a normal test x-ray may rule out pneumonia, something that we see. It rules out pneumonia, allows us to move forward. If that rule out there, thinking about sensitivity in here. And so I want to have the chest x-ray. I don't want is going to be looking at it. I don't want to see false negatives. The rule in is to select a proper diagnostic test. The most specific test, again, should be used to confirm and rule in a diagnosis, just as Dr. Weber just said. Have the profile, have a number of pieces, and I'm able to rule in a particular disease and condition. Pretty much kind of general types of rules, just general rules. As a rule of thumb, a test with at least a 95% sensitivity and a 75% specificity should be used well to rule out a disease. And a test with a 95% specificity and a 75% sensitivity, again, can be used to rule in a particular condition. So again, kind of looking in here, high sensitivity, okay, rule out snout, high specificity, spin, rule in a condition. If we're doing screening, which most all of us do, this is where our big interest is, right up in here. So let's think about screening for potentially fatal disease like tuberculosis or hypothyroidism. A rule out test would be very useful because there's a penalty, if you will, for missing, there's harm for missing a diagnosis. So I want to have that. Screening tests use tests with high sensitivity to minimize the false negatives. So this is where we're thinking. We can even look at this in blood pressure. We want to make sure that we identify, we don't want false negatives. We don't want to send someone by and say, you have no worries about blood pressure. Go on, keep on doing what you've always been doing. No, we want to be very careful with our false negatives. So as we screen, same with glucose and many of the conditions that we have with screening, we want to rule out the disease, and we want to minimize and ideally eliminate the false negatives. So a little bit here, just okay, right. If we just a little bit here, this is just one kind of example of how you would kind of look and think and thinking, I want to look at, identify undiagnosed diabetes. So here's just some, they were taken in there, but just to give you an example of how you would look at this, this piece. And so I'm looking at, in this particular case, probably what, well, I want to identify the diseases, and here are the roamings of the specificities. So hemoglobin A1C for undiagnosed diabetes, 50% sensitivity, specificity 97%. Hemoglobin A1C with a cut code or a threshold of 6 as opposed to 6.5 has a sensitivity of 73 and a specificity of 87, and a fasting blood glucose at 104 milligrams per deciliter has a sensitivity of 82% and a specificity of 89%. The question is, in this particular case, we're looking to identify undiagnosed diabetes. Okay, so kind of looking and kind of wanting to kind of rule out these conditions, and you would see how you would select, again, very quickly based on what tests we were going to use, as well as maybe what threshold you would want to select as a particular test. Now we want to implement that diagnostic test. We've kind of selected what we think might be best. Now let's get ready Let's implement it. And what are the considerations that we have here? Again, now this is where we're bringing in the predictive values and the pieces. So we put a test together. We now want to know, we want to have an assessment of that particular test and what its performance is in the purpose in which we were trying to implement. Now we're thinking about the positive predictive value. Now looking at the percent of those with a positive finding who actually have the disease. The negative predictive value reveals, again, what percent of those negative results do not have the disease. Pretty simple type of an equation. Big piece here, sensitivity and specificity stay with the test. The positive predictive value and the negative predictive value are affected by the prevalence of the disease in the population. The value is really dependent on the number of people, the prevalence of the disease, a little bit different. Remember, now I'm implementing, so I've selected a great test, but now I want to ask the question, is it appropriate to use this test on this population? I now have to consider the prevalence of the disease. So here it is, just kind of putting it together as we would think, the positive predictive value. Now, the denominator are all those people that tested positive. So what could happen is I have my true positive. That's great. They actually have the disease. Here they are. That's exactly what I want. But they could also be testing positive, and these would be false positives. Okay. So what's happening? Sometimes there's difficulty. There's a biopsy, or there's further follow-ups, further tests. Sometimes those tests have further harm, this kind of stuff. Sometimes they don't. Sometimes the benefit is okay, and you might accept some false positives. That might be okay. Negative predictive value, same way. The negative predictive value are those individuals that test negative. Okay, what could that happen? Well, first off, the true negatives, the people don't have the disease and they tested appropriately. But could be some people that have the disease that were false negatives, that your test failed to detect the disease, and it's there. What are the ramifications for the false negatives? Okay, maybe there aren't any harms. And so you're thinking the condition and the ramifications and the concern about the false negatives. Formulas, we've kind of done that. Positive predictive value over all the true positives divided by all the people that were identified as positive, the negative predictive value, the true negatives over everyone that tested negative. This is kind of a little quick schematic as we kind of look and think about positive predictive value, negative predictive value, and thinking of what this direction is. So in this particular case, you have these cases and you have patients or people with the disease, and you have healthy people without the disease. You've got a test that's basically 66.6 positive predictive value and a 100% negative predictive value. Okay. In this particular case, the negative predictive value, again, this is basically saying we have no false negatives. We're not putting anybody out on the street. And this is what this would this would look like. So if I'm looking at this kind of piece, and I'm looking at this, so what I'm seeing here is I am identifying, in this particular case with 66.6, I am identifying nearly a third of the people that test positive are really healthy or healthy. They're false positives. So what are the ramifications of the false positive? It might be a repeat test. I just had to do the test again, or something simple like that. So not very much harm. Sometimes there could be some harm. But in this particular case, I want to make sure I don't have any false negatives. And I want to, and in this case, this test and this threshold would be set up, but I'm going to accept a few false positives in here. And I'll do something with them. I've determined that the cost and the health is, and the risk is not, and harm is not very great. But there's great harm if I do not identify the person with the disease. And in this kind of scenario, I think this is what you see. And I know Dr. Weber, Dr. Welton, y'all see this quite often. And I think this is, as we assess a particular test and a diagnostic, I think this is basically the general thoughts, particularly as we think about screening.
We often apply this in high blood pressure.
Yes.
We're willing to accept a few that are false positives because the treatment may be beneficial even at slightly lower pressures, and we'd rather treat them and not miss somebody who really is going to have a lifetime of high blood pressure than the reverse. The treatments are rather inexpensive and very safe. So we tend to want to err on the side of over treating, if you will, and picking up some false positives that even may later in life or shortly afterwards get into the higher blood pressure range anyway.
Great. Well stated. So as we kind of put these things a little bit more together, again, when a disease is highly prevalent, the test is better at ruling in the disease and less so at ruling out the disease. The disease prevalence should also merit considerations when providers examine their diagnostic test metrics and interpret these values from other providers and researchers, kind of building in here disease prevalence kind of considerations. So what works in a population with a high disease prevalence might be less relevant in a population with a lower prevalence. I'd like to go back to Professor Welton's comment about blood pressure. That's one of this, why blood pressure is so exciting in this particular area, because I think we'll all kind of agree there's not very many populations that are not affected by elevated blood pressure and high blood pressure, unlike some other conditions. When we think about all the diagnostic test outputs, again, the issues with the results are again, part of the consideration. Is this acceptable for a particular setting? If I'm looking at diagnostics in a hospital and clinic, as Dr. Weber has brought up, am I looking at screening? What am I looking at in the considerations? Are there alternative diagnostic methods or tests? All kind of considerations, again, going back to that original thing. Why am I doing the test? And what do I want to find and see? Am I okay with having some false positives in there? Is it this way? Is it this part? And now I'm identifying the test and the appropriate way to do. Just to have this is again, this is an infectious disease, not part, but I think just to kind of show you, to demonstrate the impact of prevalence. This is looking at HIV prevalence and thinking about the negative predictive value and the positive predictive value. And I'd like to focus in on the positive predictive value of looking at HIV testing. Notice, boy, when the prevalence is low, okay, the positive predictive value is low, okay? As we move across and the prevalence goes up, in some cases, just looking at this 30%, if we're looking at the positive predictive value of the HIV point, it goes all the way, nearly up to 100%, 98% of positive predictive value. Very, very strong. And if you're doing two reactive tests for HIV, you're actually getting to the 100%. this is the point. The point of this is not a whole lot here with HIV. I think many of you already know this piece, but to emphasize that point of looking at HIV prevalence and its impact, particularly on the positive predictive value of the particular test, or the reactive test, excuse me.
So that's a very interesting concept, Dan. So am I interpreting this right? If I'm looking to see if someone has HIV and I test for it, and I'm in an area where it's pretty uncommon to have HIV, there's a relatively low prevalence. Should I be thinking, even if I get a negative test, should I think about repeating it? Is in other words, not just saying to the patient, "Don't worry, you don't have it." Should I think, well, just to be sure, should I do it a second time?
I think this would indicate with HIV, I think that's going to be exactly the manner in this particular test. And this is part, as you can see, if you did it on one reactive test and the prevalence is very, very low, that positive predictive value is probably not very useful. In this case, they did a repeat test, as you've suggested, and now the positive predictive value dramatically increases where the value might be of some value. That's exactly what you would what you would see and what you would expect. Well stated.
Okay, that's a very important point. Thanks, Dan.
Yes, where the single value has value in a high prevalent area. So you could have this piece, and you see this quite often, and it's driven a bit by the specificity. While it's very high, but it's really guided by the prevalence of the condition. Here is one more. This is a sample of 100 people, 50 healthy. This is a little bit taken from that hypothetical example that we had earlier. The test was positive for 75 people in the population, positive predictive value, negative predictive value. The following, we come up with a 66%. This means, again, that if the population, 66% of the people whose test result is positive would actually have the disease, 2/3. Okay, looking at the prevalence. The negative predictive value, 25/25, this means that in a population of 100, 100% of those people that would test, the test result is negative, are actually indeed healthy. Again, kind of going to that same part of the impact of the prevalence of the condition. I'd like to do another one because this really kind of fits in. This is Lyme disease. It's a condition, I'm not sure how it is globally. Lyme disease is a tick-borne condition prevalent in North America, and I'm sure other places as well. But it varies depending, different places have a higher prevalence of Lyme disease than do others. So again, another kind of example, this is the prevalence of Lyme disease. Again, if it's high, the antibody test has a high positive predictive value. Higher the prevalence, higher the positive predictive value. In patients who live in places where the disease prevalence is low, the same test has a low positive predictive value, where you'll see it could be so low that some people don't do that test, even though a person could potentially have Lyme disease. They don't do it as an early early assessment. And this is an example of what you would see. Here is the sensitivity and specificity. Remember, stay with the test. Good test. In a high Lyme disease prevalent area, let's say of 20%, the positive predictive value is 83%. Probably something that we can have and use. In a low Lyme prevalent population, where the prevalence is only 2%, the positive predictive value drops down to 28%. Now you're telling that the person that they tested positive, but they have a better than not chance that they're actually disease free. The test is less valuable driven by the prevalence of the condition. One more, just kind of moving a little bit more into our into more of the chronic diseases and NCDs. If we think about routine echocardiogram during a yearly physical to see if everything is okay, kind of going back to what Dr. Weber was going. Physicals are falsely positive in nearly 50% of the people with an abnormal test, just if we're just doing it for no real good reason. As a result, the test is likely to harm patients by inducing further unnecessary tests. So it's just kind of a exploratory, just checking out just to see if everything is all right. And again, that 50% can be kind of low. And here's where we kind of bring it into that capacity. The patients are perhaps at low risk. They're reasonably healthy. So the prevalence of the heart disease in this condition is only at 10%. So the test, the echocardiogram for just checking is 90% sensitive, 90% specific, fairly good, but the positive predictive value is only 50%. Kind of toss, flipping a coin to determine if the patient has heart disease. One more, looking again at another NCDs and looking at these conditions, kind of thinking about this is from the Lancet proteomic pattern screening for ovarian cancer, said it's better than the CA 125 to identify ovarian cancer. We have the sensitivity of the test at 100% and the specificity of the test at 95%. However, since the prevalence in women of ovarian cancer less than 35 years of age is only 1 in 2,500, you get this type of a pattern, and you're looking at it, and you make that condition that it's better than the CA 125, sensitivity at 100%, the specificity at 95%. We spoke about the prevalence in this condition, 1 in 2,500, and this is going to be this is the concern that you have in here, a low prevalence, and this is going to come out to about 0.8% positive predictive value, basically saying that 99.2% of the test, while very strong, will be falsely positive, kind of doing harm, in which we're now finding a positive piece in this part. So prevalence makes a huge difference, even though with a high sensitivity, and prevalence influences the positive predictive value in particular. I got one more, and we think again, if we think about AMI as a final diagnosis in 17% of the patients, we have this 2-hour algorithm that classifies as 56% of the patients as rule out and 17% of the patients as rule in. The resulting diagnostic sensitivity and negative predictive values again were 99% at 99.2% and 99% for the rule out. The negative predictive value again 99%. Specificity and positive predictive values again 95% and 75% in the rule out. Thinking about again looking at these final conditions that we see. If we look at one more and we think about this is one a little bit, I think maybe the content and the pieces, please kind of stay away from just a tad, but let's look at the cutoff points that we have for this BNP as we look at this and thinking about looking at congestive heart failure and these other kind of conditions. So if I look at the cut points, and as I get greater, my sensitivity is lower, my specificity good. And I'm moving, what I'm now doing is moving the cut point and these pieces. So depending on what I want to see, if I look at the positive predictive value of this particular test, I'm seeing that it increases as I move my threshold higher and building it forward. So it gets stronger as I'm moving this, and I think this makes sense as we move it forward. In turn, the negative predictive value goes down. If I'm looking at accuracy in the diagnosis, okay, moving my threshold up, and the point is not the specific values here or even congestive heart failure. It's thinking about as I'm moving that threshold, or I'm interpreting the results based on where the threshold seems to be and the influence of that cutoff level. And this is kind of explaining it here. At the lower BNP cutoffs, there's a higher sensitivity, better ability to identify the patients with congestive heart failure. Although this is compromised by the lower specificity. The corollary of a higher sensitivity is higher negative predictive value. The test performs as a rule-out test, kind of in the screening, and enables the clinician to consider other causes of especially and other than congestive heart failure, ruling out another condition. Conversely, if we have higher cut points, they are more likely to identify patients with congestive heart failure, higher specificity, positive predictive value, again, are better rule-in types of tests. Just getting you kind of thinking about the different parameters that we would have that we can kind of consider. I want to just kind of touch on, we've got the international experts with us, Dr. Welton, Dr. Weber, and I think kind of bringing these concepts into our ideas and our thoughts with regards to hypertension that Dr. Welton's already kind of brought in and thinking in here. If we think about hypertension and the considerations that we have, well, the first one with blood pressure is blood pressure variability. So in one sense that we've been saying, maybe that single blood pressure measurement may not accurately reflect the person's true blood pressure. So maybe I want to say for a diagnosis, it's multiple multiple measurements, multiple considerations. That's what's going to fit in there. Dr. Welton, did I say that properly? That you're looking for multiple blood pressure measurements?
Yes, and we'll get two components of variability here. We'll get what we call a systematic component. Certain things occur all the time, and we'll get a random component. So when somebody walks in off the street, they're not used to getting their pressures measured. They walk in and they're tense, and they see all these people in the white coats, and they hear the doctor's footsteps coming to the door, tends to put their pressure up. So we know systematically that first pressure is often quite high. If they're very used to blood pressure measurements and sort of casual about it, the first pressure may be about as good as the other ones. But there's also a random component. Just unpredictably, blood pressure varies, and that occurs during the visit. It's actually a bigger component between the visits. So we average to deal with that. So those are the, variability is a very big issue for some tests, including for blood pressure.
Yeah. And
there's another issue too, Dan, that has been recognized, and Professor Welton has given some very clear recommendations in our guidelines, and that is that sometimes the blood pressure in the office is falsely low. And when you think about it, there's a logic to that, because someone who's living a fairly active life, coming to a doctor's office where people are often very kind and thoughtful, it can in some cases be a very relaxing environment, may actually have falsely low blood pressures in the office. As soon as they get home or go to work or wherever things are moving somewhat more frenetically, the pressure may be considerably higher. And so we're to be sure we're not getting we're not falsely ruling out people who really do have hypertension. it's sometimes very helpful to get blood pressures that are measured at home or in other places.
Right.
We do have methods for measuring blood pressure all day long, so-called ambulatory blood pressure monitoring. That's not always available in many parts of the world, not even here in the United States. So encouraging people to get blood pressures measured at home can be quite helpful and reveal people who've got a blood pressure that's higher than we really thought it was, just based on what we found in the office. So I think the work that Dr. Welton has done has really illuminated the importance of looking for false negatives. And I think that's a huge contribution.
Yes.
And of course, the challenge is we're interested in somebody's average or usual level of blood pressure throughout the day. And when we see them in the clinic, we're just seeing them for a very short period. And is that measurement in that short period going to misrepresent either to be too high, which is the more common case, or as Dr. Weber said, to be too low, which certainly can occur. And it's a small window on blood pressure, and that's often the problem with tests that are pretty variable, because you see the patient at one point in time, and what you get at that point in time may not reflect very well what you're really interested in, which is the overall experience that that person is having throughout their life.
Well stated. And we consider, again, where was the things to think about? Blood pressure variability, how many blood pressures were measured, the setting of the blood pressure. Was this an office-based? Was it out of the clinic? What were some of the issues? Another one I know that both of you have worked with a great deal is the issues of secondary hypertension, that there's actually a condition or something or a cause for the blood pressure. I think that's been estimated at about 5 to 10% of the blood pressures are what we would consider to be secondary. So now you would want to have one of those additional tests to consider or basically to rule out one of the secondary causes. And one that I know that we've all seen right now is this other considerations in the diagnostics, and that's the health information from the technology, in particular, electronic health records. Again, you can, getting into this part, is this a way to maybe back up maybe some of that single blood pressure measurement, the office-based measurement? What are some of the other values that you'd be able to identify from something like electronic health records and health information technology? Again, building it to it, that there's more to it, the strength of it, the strength of sensitivity, specificity, positive predictive value, all kind of dependent on good, accurate blood pressure measurement, and making sure that you're understanding the condition when we're making a diagnosis.
Just a quick comment on secondary hypertension. We don't need to go into the details, but it has changed so much during my time as a physician, because we used to think relatively uncommon, and we really look for it in young people. Now, with the epidemic of overweight and obesity, we see what's referred to as sleep apnea very commonly, particularly in older people, and it's a very common cause of higher pressures. We also see people getting over-the-counter medications. Usn't to be common at all when I was starting. Now is very common. A very high percentage of people are taking medicines that will increase the blood pressure level, particularly older people. Are frequently taking agents that are anti-inflammatory for pain, or they're advertised a lot. So it's interesting, just during a relatively short spell in my lifetime, we've gone from saying secondary hypertension is quite uncommon to saying now it's actually rather common, especially as you deal with older people.
Excellent. Thank you. Brilliant point. This is one I think that kind of, as we get ready to kind of slow down and wrap up. This is looking at the undiagnosed hypertension, which is an area that we're thinking, and this is where the screening part means so much. In this one particular study, they revealed a hypertension prevalence of 38.5%. It's a different group, and an undiagnosed hypertension rate of 50.9%. And those with undiagnosed hypertension were predominantly adults over 60 years of age with low, in this particular study, and individuals with low education, without prior diagnosis of other chronic morbidities, and as Dr. Wilton just well referenced in here, with obesity and overweight conditions. Again, that kind of undiagnosed hypertension. And pretty much undiagnosed hypertension, again, was significant among populations without risk content. And they're so basically saying we have an urgent need for community-based early detection and education strategies. Early detection, now we're going in with blood pressure measurement. Now we're going to need to consider, are we doing, is our process measuring it? And then what are the consequences, as we have said, of a false positive? Are there consequences? Well, a little bit, but they're minimal types of harm, as opposed to allowing people to go out as undiagnosed hypertensives. So we're going to rule out for hypertension. If we think about, some people say this is kind of low, but think about what we're doing with something like blood pressure. If we say a normal blood pressure 120/80, you're thought to have elevated blood pressure, in which you are likely to develop high blood pressure if you don't control it, if your systolic blood pressure is between 120 and 129. And again, in this particular case, defining high blood pressure as 130/over 80. And I'm going to kind of ask Dr. Welton, Dr. Weber, there's perhaps a little bit of at least discussion, but if we're doing screening, is this a reasonable scenario?
Well, yes, this is. And certainly someone who's got a blood pressure above 120, you're going to say, well, not necessarily need to do anything about it right now, but you are potentially at risk of moving into, as you get a little bit older, and you get older pretty quickly,
Yes.
you may need to keep on getting your blood pressure checked, because I suspect sooner or later you're going to need some kind of treatment. And the prevalence of hypertension changes with age, and by the time when you look at young people, the prevalence may in fact only be 20%, 25, 30%. As you get to middle-aged people getting into their 50s and 60s, then the prevalence gets up to over 50%. And by the time you get into 70s and 80s, then I won't say just about everybody, but pretty close to just about everybody has hypertension. It's very, very common. And for those people who are practicing clinicians, doctors, nurses, nurse practitioners, physician assistants, all sorts of people with medical training who see patients, we should always be aware that older people probably do have high blood pressure, and we should recognize it and deal with it, because if we don't, there are going to be very serious consequences: strokes, heart attacks, heart failure, kidney disease, and so forth.
But when we're in the lower pressures, we're usually recommending people to have a healthy lifestyle, and we don't need to get into a lot of details. Most people know what that is. I remember going to my son's class when he was very, very young, and I was shocked when I asked them what are the risk factors for heart disease, and almost everyone in the class knew the major risk factors, and they were 7 or 8 years old. So we can counsel people and encourage them on a healthy lifestyle. Then as the pressures begin to creep up a little bit, starting to get into the 121, 129 and that area, we can be more specific about trying to ferret out what unhealthy lifestyles do they have, what are the more important ones, what ones are they interested in changing. Some people are not interested in changing. Let's say they're drinking more than we would recommend, and any drinks will put blood pressure up. But they say, well, I like my lifestyle, I'm not going to change that. There's no point in wasting your time at that. You go after another one where maybe they're willing and interested to improve their physical activity. And then as we get into the higher pressures, the 130 and above, we're really interested in underlying risk, and do we need to add on medications at that stage. So sort of a graded approach, but we're always, for chronic disease, particularly the cardiovascular ones, we're very interested in lifestyle and trying to help people to prevent, because it's always better to prevent than to treat.
Yes.
At a given level of blood pressure, if somebody has disease, they're obviously at higher risk than somebody at that level of blood pressure who
Yeah.
do not have the underlying disease.
So, Dr. Wells, if I might just kind of pile on. So there is value at looking at this, at identifying someone at greater than 120 to 129. There is a value in looking at that systolic blood pressure.
Yes, it's like the traffic lights, isn't it? I mean, you have a green and you say, you know, you're in pretty good shape, just keep it up. And some people do. Dr. Weber is correct, of course. Most people, as they get older, have high pressures, but there are a small percentage of people who can go throughout life, and they are with low pressures, and they're usually the ones that are most careful about their lifestyle. And then as you start to get up, you say, well, that's an orange traffic light, and it's going to go red if you don't take care of the situation. And then you get to red, and you really need to work hard with them to try to improve things.
That's right. And I think this is kind of saying that while there may be a risk of an overdiagnosis at the lower threshold, it's still is important, and it is something to look and consider for hypertension. Maybe other conditions maybe change just a tad bit. So this is how we wanted to kind of bring this in, and thank you for this great discussion. I appreciate everyone kind of listening. Want to just kind of close out with some other aspects of it. Hopefully you're receiving the World Hypertension League newsletter. We include a lot of these type of information. We're going to start with this version. The September issue of the newsletter will include actually a little bit of a short write-up about from this group on a particular topic. And so we would ask you, if you would like specific topics addressed and stuff that we can address in the newsletter in the future, please let us know. And very, very important, again, your question and answers. There is no bad question. Every question, please ask your questions. What we do is reply in writing and post those on the World Hypertension League website. The answers, the specific question, and we try to give you a specific answer that's there. So please send in your questions, and we will get those posted as quickly as we can. And we're real excited again to emphasize and hope you will consider the World Hypertension Congress in 2025. The dates of that Congress are going to be March 7th through 9 in Chennai, India. I think it's going to be an exciting part. We would hope you might consider coming and being a part of us. You get to meet Dr. Weber, got to meet Dr. Welton, and that in itself would be worth attending. And just an exciting part that we can actually share some of the thoughts. There'll be a lot about hypertension, but almost everything anyone's doing, I think, would be very relevant to coming and participating.
You'll have a scientific writing series that you're going
right
to
here.
be. Oh, sorry. Go ahead.
No. You're doing this is perfect, and I appreciate it. One of the pieces that we are saying is that we are going to have, as Dr. Welton said, a scientific writing morning service. So on each morning of the conference, on day 1, day 8, and March 8th and March 9th, from 7 to 8 a.m., we're going to have some of the leading experts in scientific writing there and being right here. And our themes are going to be each part: preparing a manuscript for publication, targeting journals for submission, and the manuscript review process. How do you revise a manuscript, responding to reviewers and editors and building it forward? We think it's going to be an exciting part. And also another part of that would be an opportunity for perhaps you to bring some of your thoughts and share with some of the faculty for the workshop about what might be a direction that you can take specifically your workshop. So we would love it if you would maybe kind of consider coming. We would love to have you come and participate with us.
And all three of us are involved as editors in various journals, and we'll have the editor-in-chief, another colleague of ours, Michael Stillwasser from Journal of Human Hypertension, will be there, and I know he'll be looking for submissions to his journal. So it's going to be a very nice opportunity.
Exciting. Thank you, Weber. And then finally, I think it's an opportunity for you to share your work if you would like to. The abstracts are open for submissions. Now, think maybe kind of take a look at that, and we would certainly welcome and be excited to see any submissions that anyone would like to bring forward. And with that, I will stop and thank everyone.
Thank you. Thank you very much for this informative and amazing presentation. Your clear explanations and detailed examples were so helpful in understanding the application of predictive value in diagnostic testing. So thanks again, Professors Lackland, Weber, and Welton. Everyone, if you could type your questions in the Q&A chat box, that would be great. And before we open the floor for questions, we have some poll questions to work on together, and I invite Kesser to read the poll questions. Thank you, Kesser.
Thanks, Shma. So we have 2 poll questions for you. The first one, the scenario is about the Deputy Minister of Health, whose brother has ALS, which we know is a fatal progressive condition. The global prevalence of this condition is estimated to be between 1.9 and 6 cases per 100,000 population, so low prevalence. The threshold tracking TMS technique has a sensitivity of 73.21% and specificity of 80.9 for early stages of ALS. Since the minister is really dedicated to this cause, he wants your guidance on implementation testing for all young adults. So what we would like you to do is take a look at 4 options and pick your best response and type it in the text box or chat box. Thanks. So let us know if you would respond A, B, C, or D.
We have lots of C's.
This is a great group.
Yep.
Yeah.
So Dan, what do you think of this response?
I think these are superb responses, and I'm very excited to see it. And I congratulate you on the response. C is basically the proper response, at least in my opinion. The prevalence is just so low that this would not have a great deal of value. But a little bit concerning, if we went out beyond this group is great, and they got this message and they understand the impact of the prevalence. There's a lot of folks in healthcare, though, that would not get this one correct. They would probably lean towards A and implement that type of a system, and think about what you would then be having, and that's all of these folks with false positives, and offering a very a real concern that you're, for something like ALS, boy, it's not good to have that as a positive diagnosis. That will kind of take away and be very very confusing. So I'm excited to see this, and I think this is really an important piece. Dr. Weber, I think you see these kinds of things. I think you would probably agree, boy, it's important that we understand the answer of C and why that's the most appropriate.
Yes, no, I agree completely with C. The sad thing about this particular disease is that even if you identify it early, it's not likely to materially change the outcome, which unfortunately is not a good outcome.
Right.
So it's not as though by missing the diagnosis early, we're really increasing harm. We're not. It's probably, frankly, better to diagnose it when it becomes symptomatic and not have people develop anxieties and deep concerns where if they know unnecessarily that they're about to have it. Now, I agree totally with C. There's no, we're not missing anything important.
Okay, great. Thank you. Great.
C it is. And then we have one more scenario. So this one refers to the increasing overweight and obesity epidemic that health departments worldwide are concerned with. And as we know, we measure this as BMI, or body mass index. Here we have the positive predictive values with 95 confidence interval for 4 BMI categories: underweight, normal, overweight, and obese class 1. We're asking you to advise the health facts writing team on using BMI as a tool for assessing excess body size. So again, you have several choices to look at, and we would like you to type your best response in the chat box. Okay.
Okay. This is when and I'll apologize, everyone. It's a little bit tricky because there's maybe more than one right answer, and on this one, and I think this is a real. I think many of you will already say, "Boy, this is a real case right in here." What are we basing? We say that the world is getting, the trends in obesity are going up, and we're building, and we're finding that different people have different definitions of what obesity is. We'll agree it's going up. I think that that part's there, and maybe want to be kind of specific. In this particular case, I would have gone with E and C and D. And so for A, those of you that are with A, that you're not wrong. There is typically, we do use BMI, particularly on population types of things, because it's relatively easy to do and everyone can do it. You just need basically a height and weight. Is probably because there was a great deal of variation in the positive predictive values of by the different categories, and so I would be a little reluctant for B, because that probably wouldn't work. For C, as the report address excess body mass, report overweight and obesity as separate categories. That's probably what most reports do. What most papers do is put them in two different categories, and then you're able to kind of assess and distinguish between overweight and obesity as separate categories. So that would be appropriate. Most of you have got that as well. D, though, could also work if you look at the positive predictive value and you're seeing they're so close. They really are kind of in that, really almost kind of describing the same thing. So if you were to say, I'm going to put overweight and obesity together into one category and call it overweight and obesity there, and I think with regards to the diagnostic characteristics, I think they would be similar, such that putting those two together would be fine. And if you had that type of logic, probably something like E could possibly be the right answer. But for the most part, C, D, E, you're working in there fairly well. So a little bit of a tricky question, but I think everybody did really well on that.
Thank you.
Yeah, I agree, Dan. I think people did well, and I think those are in a sense, the right answers. Of course, one of the issues with BMI is that its relationship to the risk of adverse outcomes, premature heart disease, strokes, kidney disease, and so forth, diabetes, obviously, all important outcomes of having excess weight, excess BMI, vary from country to country. They vary probably somewhat between men and women. And there are now studies suggesting that there may be cleverer or more accurate predictors of adverse outcomes than BMI that take into account not just height and weight, but perhaps height and waist circumference. That's one approach that's just been recently reported in a major journal. And I suspect this is a work in progress, but yes, just using BMI right now is a very useful tool, important to know, and a great guide for policy, and a great guide for all of us who see patients in advising patients about the importance of doing something about excess weight.
That's right. And this idea, this part, certainly this is, we're talking about obesity and body mass and anthropometrics, but this is, you will also see these same types of stuff, and particularly we'll go to blood pressure. So if I had stage 1 hypertension and stage 2 hypertension, I would probably want to look to see how good are those definitions. I would want to look at the perhaps positive predictive values for those two categories. And again, if they're really close, and I want to kind of present the impact of overall the hypertension categories, sometimes it is possible to kind of report and look at that. But you do want to look at how strong are the diagnostics for those different categories, and other conditions as well, all the way through. And sometimes it's appropriate to combine. Sometimes maybe it's not appropriate to combine, both on the diagnostics as well as as Dr. Weber was saying, the impact on what the outcome of why we're actually putting someone in a particular diagnostic category.
Well, we've certainly, the moment you start now talking about BMI and weight, and I'm sure this is a worldwide phenomenon, but one we're seeing very much in the United States. People are now taking quite expensive drugs used typically for treating diabetes, the so-called GLP-1 agonists, which are expensive, in some cases quite expensive medications that are effective at helping to reduce weight as long as you take them. And as a clinician, I worry about this, that we're coming up with short-term solutions, expensive short-term solutions, when really we should be working harder and harder at educating the population about the dangers of excess weight and other ways of keeping the body weight under control.
Excellent.
Thank you. I'm going to turn it over back to Sushma.
Thanks, Kesser. Thank you, everyone, for participating in the poll questions and for this insightful discussions. Thank you also for your questions. Unfortunately, we won't have time to go through the questions, but as Dr. Lachlan mentioned earlier in the session, the answers to all your questions will be posted online at the WHL and TAFINET websites. So please make sure to visit the WHL and TAFINET websites. And a quick reminder that we are starting a new two-part webinar series on critiquing a published article. And please note that both parts will be in October next month. The first part is actually scheduled for October 3rd and will focus on the manuscript peer review process. Please stay tuned for the registration link and all the details in the following weeks. And I just want to point out that there's been lots of requests for recording and the PowerPoint slides. We will share the slides and the recordings to everyone who attended the session today, and they will also be posted on the WHL and TAFINET websites. This is all we have for today. We thank the WHL faculty and everyone who participated in today's session. We really appreciate your time and attention. And we would also like you to request to complete the evaluation form by using the link that we just put in the chat box, or you may also use the QR code that you see on the screen. Your feedback is important to us, and we look forward to seeing you all next month on October 3rd. Please stay tuned for the registration link and all the detailed announcements in the following weeks. Thank you so much. Have a wonderful rest of your day. Thank you.